Good morning and welcome everyone to today's session. My name is Marie Latulip and I manage some of the nutrition programs at our organization. We're very happy to have you join us today. And just a quick note for those of you who are not familiar with us, we are a nonprofit scientific organization. We advance food safety and nutrition science for the benefit of the health of the public. And we always like to note that we do not lobby and we don't do any advocacy work, rather we focus on the science. And this webinar is approved for 1 continuing education credit for registered dietitians through the commission. And to receive that certificate, you will receive a very short survey after the webinar today. Just complete that and we will email the certificate to you. So with that, I am very pleased to turn the platform over to Dr. Rick Mattis of Purdue University. Dr. Mattis was also a member of the 2020 DGAC, Dietary Guidelines Advisory Committee, which looked at sweeteners in beverages and some weight outcomes. So Dr. Mattis, I will turn it over to you to kick this off.
Great, thanks, Marie. Today's program focuses on 2 systematic reviews. So we should probably start by defining what that is. We'll use the definition that a systematic review involves answering a very specific question using predefined processes that determine the strategy for searching the literature, for example, which databases to include, the criteria for which papers are included and excluded, things like sample size, study duration, population characteristics, outcome variables, and very importantly, documentation of all decisions. The goal is to define the process so clearly that it can be replicated by others. A conclusion is then produced and is rated for strength of the supporting evidence. I should note that it's not uncommon for systematic reviews on a similar topic to yield discrepant outcomes. This doesn't necessarily mean they're conflicting or one is wrong, as the conclusion depends heavily on the decisions made throughout the process, hence the need for precise documentation. And even subtle differences can result in different outcomes. A stellar example of this in the area of sweeteners is the difference in outcomes if the review is based on randomized control trials versus prospective cohort studies. The RCTs often show more beneficial effects on body weight outcomes than cohort studies. Next slide. The 2020 Dietary Guidelines Advisory Committee actually conducted 33 systematic reviews, several on use of low-calorie sweetened beverages with an outcome related to adiposity. As shown here, the evidence was judged to be insufficient or limited for each. However, seeing a lack of association with adiposity, the potential for individual variability in responses, and no evidence of a harmful effect on this outcome, the committee concluded that low-calorie sweeteners could be an option specifically for weight management. Next slide. Today we'll hear about 2 other systematic reviews published in 2020 that look at low-calorie sweeteners and weight-related outcomes. I'm pleased to introduce our first speaker, Dr. Hugo Laviata, who is a physician and full-time professor and researcher at the Marista de Merida University in Yucatan, Mexico. He studies dietary and lifestyle interventions to support diabetes management, has produced many peer-reviewed publications on the topic, and speaks internationally. He served as senator representing Yucatan and was a member of the Senate Health Commission. Dr. Laviata, the floor is yours.
Thank you very much, Dr. Mattis, and thank you very much for the seminar organization to invite me to share our work in low-calorie sweeteners. Can you see my screen?
Yes, we can see it.
Okay. We are to talk now about low-calorie sweeteners and body weight in diverse clinical conditions. This systematic review was focused to review what happens in the different scenarios, because as Dr. Mattis said, the results are very much dependent on the selection of the studies. So we focus in review how the different design and the different comparators results in different outcomes. This is my disclosure. I have received fees as consultant, speaker, and funding from different companies. None of these entities had any involvement in the preparation of this webinar. First of all, I'm going to introduce you about some of the differences Dr. Mattis mentioned from observational and non-randomized studies that generally include a good amount of subjects, like this one that was published in about 10 or 11 years ago. And this is a very known pattern of observational studies. For example, this one, this studied diet soda intake and risk of incident metabolic syndrome, including, of course, obesity and hyperglycemia, comparing people who used to drink dietary soft drinks with non-consumers. And the results concluded an association, not necessarily causal relationship, that the daily consumption of soft drinks sweetened with low-calorie sweeteners was associated with an increase of 36% more chance of developing metabolic syndrome, including obesity. This our topic now. You can see here, this is the table that is generally shown in this kind of studies to show the characteristics of starting the study. And you can see as observational studies are not, of course, randomized studies. You can see when you compare people who rare or never drink dietary soft drinks, you can see that they are in lower BMI. They have less centimeters of waist circumference, and they choose to eat less food and less energy. If we compare 2 more points of BMI, 5 more centimeters of waist circumference, and almost 200 calories more ingested by people who used to drink low-calorie sweeteners in form of drinks in this case. What you can see here is that there is a problem when you compare these people who already is consuming these drinks, that there is a high risk of bias because they are not starting in the same conditions. People who are followed and observed in these cohort studies, they are not in similar or equal condition, because the design of the study does not guarantee equal characteristics between the subjects who are compared. Those who consume low-calorie sweeteners often already do so precisely because they previously have conditions that predispose them to further weight gain, and to greater metabolic deterioration. That is called reverse causality. And there are also other confounders in this kind of studies, which are well-known limitations of the associations which are reported. An important proportion of participants in this kind of studies use low-calorie sweeteners because they already are overweight, trying to fight their obesity. Low-calorie sweeteners then probably is not a cause but a consequence of their problem. You can see here, this is an observational study that is a meta-analysis of observational, so it's a systematic review of just observational studies. And you can see here that it seems to be a 25% increase of relative risk of being, in this case, diabetic. As you know, the type 2 diabetes is very much intimate, has an intimate relationship with obesity. But if you use a statistical adjustment by adiposity, you will see that the relationship reduced substantially. That means that obesity is the presence of obesity in people who is already using low-calorie sweeteners is conditioning this apparent relationship, which seems not to be causal. But what happens when we review this same topic, examining now controlled clinical trials, randomized clinical trials, where patients are randomized to ensure that the groups that are going to be contrasted are similar and are really comparable between them? What happens when the intervention is controlled and compared against placebo or other comparators? And that's I'm going to show you that what happens, for example, in this recent systematic review, Cochrane systematic review, reviewing what happens when with low-calorie sweeteners in people with diabetes. And they found, this was published this year, last year, sorry, and you can see that there is no negative effect comparing with placebo, no signal of weight gain in these randomized clinical trials examined by this systematic review, and also no deterioration in lipids. There is no glycemic variation against placebo, and there is no effect on insulin levels. So there is a big difference with the observational, or some observational studies with which results seems to suggest the possibility of a relationship. I'm going to show now, this is our work, which was published last year. And what we did is systematical search for only randomized clinical trials, at least 4 weeks in duration, looking for the effect of low-calorie sweeteners on body weight, both in subjects with healthy weight and overweight and obesity at any age, and are comparing the effects of these food additives versus caloric and non-caloric comparators, and also by type of diet used in the different studies. The primary outcome was the difference in body weight between low-calorie sweeteners and the other variety of comparators. 20 studies were eligible with almost 3,000 subjects analyzed. And this is the general meta-analysis. Our general meta-analysis, you can see here, is without considering the differences of each study in the design, on the characteristics of the individuals included, and also without considering the differences on the diet provided in each of the studies. And here you can see an overall effect that suggests weight difference favoring non-nutritive sweeteners. But what is it possible to interpret these studies if we know that they are including different comparators, different kind of diet, or different state of weight, including obese or normal weight subjects? Weight differences here seems to favor low-calorie sweeteners with a weight reduction, but it's clearly that there is a great heterogeneity in the results and in clinical scenarios. What happens if we separate and take only the studies which contrast low-calorie sweetness against placebo or against a non-caloric comparator like water? You are not going to still to see a significant reduction. And the overall results of this subset of studies is shown in the non-effect or neutrality line when you compare to non-energy displacement interventions. You are comparing water or placebo, which are non-caloric, with a non-caloric sweetener. In contrast, if we only stay with the group of RCTs that compares the use of a caloric sweetener such as sugar against its replacement by low-calorie sweeteners, you are going to appreciate that the diamond moves to the left, indicating a weight reduction in those who use low-calorie sweeteners to displace the energy contained in the sucrose arms, suggesting that is the substitution, not the low-calorie sweetener itself. It's the substitution, the sugar substitution, which allows a modest but significant and a constant weight reduction showed here with statistical significance. And what happens if we differentiate the trials by the diet used in the studies? Here in the upper side of the forest plot figure, you can see the studies which include a normocaloric diet, and in the bottom, studies which were performed using in both arms weight reduction diet. Here is also with different comparators, including the studies, of course, which are substituting also sugar by LCS. But you can see here that weight reduction regimes are generally also reduced in sugars. So maybe there is less energy to displace by an low-calorie sweeteners intervention. And that's the reason you can see that for in the normocaloric diet, that maybe there is more sucrose to be substituted, you can see a significant effect in weight reduction that is not present in the calorie restricted diet. Maybe because in calorie restricted plants, there is less fabric to cut. And finally, what if we separate the trials and see only the studies which include thin people against the studies which includes overweight and obese population? And what we are going to see is that, again, the studies who were done in persons with any of the comparators with normal weight, thin people, is not showing a significant reduction. There is a tendency, but there is no showing a significant reduction. But you can see it, again, a modest but constant and significant weight reduction in these studies who were performed in overweight or obese subjects. In conclusion, in randomized controlled clinical trials that constitute the highest level of evidence to demonstrate causality, it is not appreciated the weight gain relationship brought in some observational studies and trials contrasting low-calorie sweeteners with placebo or other comparators without energy content show in both cases, in intervention and in the comparator, a neutral effect in body weight that is expected because of the lack of energy displaced. But if sugar is substituted and displaced by low-calorie sweeteners replacement, a modest but significant and consistent weight reduction is obtained. In normocaloric nutritional plans, a greater effect produced by the substitution by low-calorie sweeteners is observed. But in calorie-restricted weight reduction plans, the contribution of this substitution is likely to be overshadowed by a greater effect, diminishing the energy supply producing by the total energy cost, which is intrinsic to a weight reduction plan. So there is less margin to contribute by the low-calorie sweeteners in a very reduced energy diet. In the subset of trials, including only normal weight person, it is not appreciated effect of a reduction of weight that is indeed observed in persons with overweight and obesity. Thank you very much. Here is my email if one of you want to write and to obtain more information about this study. Thank you very much.
Thank you, Dr. Laviata. We'll move right to our next speaker and take questions at the end of all of the presentations. Please do continue to add your questions to the chat, and we'll get to those at the end. But let me introduce our next speaker, Dr. Katherine Appleton, who is currently based at Bournemouth University in the UK. She's a chartered psychologist and registered nutritionist with research interests in understanding and encouraging healthy eating on a population basis. Her work aims to understand barriers and facilitators to healthy eating and to develop and test interventions. Dr. Appleton?
Thank you. Let me just work my computer. Okay, can you see my screen?
Yes, we can.
Thank you. Thank you, Dr. Matters. I'm now going to take you through the process of a systematic review and series of meta-analyses we recently undertook investigating the effects of low-calorie sweeteners on energy intake and body weight. It is the entire process, so hopefully there's a clear understanding of what a systematic review is at the end. So to start, we all know, of course, by way of introduction, low-calorie sweeteners provide the pleasure of sweet taste without the calories, and as such, low-calorie sweeteners may play a role in reducing free sugar intakes, reducing the prevalence of associated conditions such as dental caries, cardiovascular disease, and type 2 diabetes. And low-calorie sweeteners may play a role in reducing the prevalence of conditions associated with excess calorie intakes, such as overweight and obesity. The role of low-calorie sweeteners in healthy weight management, however, has been contested, as has already been suggested. Theoretically, there have been suggestions that sweet taste without calories can increase appetite. There have also been suggestions that sweet taste, both with and without calories, can increase sweet food preferences and sweet food intakes. In humans, however, there's currently very little evidence to support these suggestions. A number of reviews have also already been conducted, as has again already been suggested, that come to differing conclusions. Earlier reviews suggested support for low-calorie sweeteners in healthy weight management, whereas more recent reviews, accepting that by Dr. Laviata, and I'll come back to Dr. Laviata's towards the end, suggest more limited effects. These reviews, though, do all differ in methodology, and so the different findings do demonstrate the importance of careful study selection and comparison. Ideally, this study selection and comparison would be hypothesis-driven. So what we wanted to do was undertake an up-to-date systematic review looking at this question: what are the effects of low-calorie sweeteners on body weight? But to do this based around 3 specific hypotheses. So our research questions were, what are the effects of low-calorie sweeteners on body weight when compared with sugar, so where taste is controlled but where energy differs? What are the effects of low-calorie sweeteners on body weight when compared with water or nothing, so when energy is controlled but where taste differs? And what are the effects of low-calorie sweeteners in capsules when compared with placebo capsules? So here both taste and energy are controlled. Our first research question, of course, relates to the primary intended use of low-calorie sweeteners to maintain a sweet taste but to reduce the energy content of a diet. Our second research question relates to more taste-specific aspects, and our third research question relates, of course, to post-ingestive effects. So to go through the methodology, we registered our protocol in advance, specifying the methods that we were going to use. We then searched the literature using 4 academic databases over all years of records, using 2 search strings to essentially find as many articles as we could find that related to our research questions. Our searches were limited to articles and abstracts published in English, but we also searched through the reference lists of included articles, essentially again to find as many articles as we possibly could. Articles were considered suitable for inclusion in the review if they included exposure to a low-calorie sweetener, if they included exposure for 1 week or more, if they included a relevant comparator, if they reported results for body weight, BMI and/or energy intake, and if they used an intervention design, so a randomized control trial or a crossover type design. For the purposes of the review, we define low-calorie sweeteners as any sweetening agent that provided a sweet taste and 0 or negligible energy content to a diet. To ensure we had as many studies as possible, where effects on body weight or energy intake could be found, we looked for any study that involved exposure to low-calorie sweetener for 1 week or more. We included studies that used that provided individuals with low-calorie sweeteners, and we included studies that asked individuals to consume or instructed individuals to consume low-calorie sweeteners, and we included studies regardless of whether low-calorie sweeteners were provided in foods, in beverages, in both, or as I've already said, in capsules. Relevant comparators were sugar, water, unsweetened beverages, placebo capsules, and we also included as relevant comparators usual diet or instructions for individuals to consume foods they were already consuming in the absence of low-calorie sweeteners. We looked for studies reporting results on body weight, BMI and/or energy intake. Our primary outcome was change in body weight, or our primary outcomes were change in body weight, change in BMI over the intervention, and also adverse events. Our secondary outcomes were body weight and BMI at the end of an intervention, energy intake during intervention, and also measures of anthropometry such as waist circumference if these were measured in the studies. We included studies regardless of population studied and also regardless of study setting. To detail our review process, our searches were conducted by 1 researcher. Search results were then screened independently by 2 researchers based on title and abstract, and all full texts were then screened again for suitability by 2 researchers independently. Data on methodology, outcomes, and risk of bias was subsequently extracted again by 2 researchers independently. And for risk of bias, we used the domains suggested by the Cochrane collaboration. Meta-analyses were subsequently conducted for all outcomes where we had sufficient suitable data. So to move on to the results, our searches were first conducted on the 14th of June 2019 and updated on the 2nd of June 2020. And you can see from the Prisma diagram here, our initial searches resulted in over 20,000, the identification of over 20,000 articles of possible relevance to our research question. Using our systematic process, we whittled them down to 60 articles which detailed 88 different studies. And for the purpose of the review, we defined a study as any comparison between low-calorie sweeteners and a comparator. To look at our first research question, how do low-calorie sweeteners compare with sugar? We found 51 studies of relevance to this research question, 37 parallel group studies and 14 crossover studies. Studies included children and adults, and the majority included males and females. Studies included a range of different low-calorie sweeteners. Interventions were provided using beverages only and foods and beverages together. The median duration of the interventions for the parallel group studies was 12 weeks, and for the crossover studies was 3 weeks. And the mean dose of sugar replaced by the low-calorie sweeteners provided approximately 13,000 kilojoules per day, 1,300 kilojoules per day in the parallel group studies, and approximately 1,500 kilojoules per day in the crossover studies. For our primary outcome of change in body weight, this is our forest plot. And just to explain a forest plot for those who are unfamiliar with forest plots, all of the studies are presented on the forest plot. In our forest plots as well, the studies are presented in order of duration. So the longest studies are at the top and the shortest studies are at the bottom. Each of the studies is then presented in the middle by a box with whiskers. The box represents the size of the study, so the number of participants. The whiskers represent the variation within the study. In our forest plots as well, studies that lie on the zero line demonstrate no effects. Studies that lie to the left of the zero line demonstrate a benefit of low-calorie sweeteners. And studies to the right of the zero line demonstrate benefits of the comparator. The combined effect, so when you combine all studies together, is presented at the bottom with the diamond. And you can see in this forest plot, the diamond is very clearly to the left of the zero line, so very clearly demonstrating a benefit of low-calorie sweeteners. Our forest plots are the same as those presented by Dr. Laviata in terms of kind of format. If we convert our standardized mean difference at the bottom to meaningful units, we find an effect size here that's roughly the equivalent of 1 kilogram body weight. Also importantly, in the forest plot, you can see an I-squared score there of 51%. We have considerable heterogeneity. The I-squared represents heterogeneity, and it shows the amount of variation there is between the studies. If you look at the forest plot, you can see there is variation between the studies. For adverse events, 8 studies in this analysis, or in this selection of studies, provided data on adverse events. And here we're looking at odds ratios, so the chances of an adverse event occurring in the low-calorie sweetener groups compared to in the comparator groups. An adverse event, an odds ratio, of 1 would demonstrate essentially no differences between the two arms. So we see here no effects or no differences in adverse events between our two groups. You can see as well an I-squared score there for the adverse events of 0. So essentially all studies demonstrating that same effect. It's a very convincing effect. We find the same effects in our other outcomes of body weight and BMI and anthropometry as we do in body weight or change in body weight. And we find the same effects also in sensitivity analyses conducted using slightly different methods for the meta-analyses and also studies of low risk of bias. We also find the same benefit of low-calorie sweeteners in energy intake. And here you can see if we convert our standardized mean difference to, again, meaningful units, we find an effect size that's roughly 940 kilojoules per day. So a benefit of low-calorie sweeteners to that extent. To move on to our second research question, what are the impacts of low-calorie sweeteners on body weight compared with water or nothing? Here we had 21 studies. These were all conducted only in adults, but the majority of studies included males and females. The studies included again a range of low-calorie sweeteners. Interventions were again provided in beverages only, in foods and beverages, and in one study here, tablets were dissolved in the mouth. This study was included in this comparison because there was a taste but no difference in energy between the two intervention arms. Mean duration of the studies was 12 weeks, and the more studies included a comparator of water or unsweetened beverages compared to those who included which included a comparator of nothing. For change in body weight here, you can see a diamond at the bottom that is very clearly on the 0 line. We find no differences here between our low-calorie sweetener arms and our water or nothing arms. You can see very clearly in this forest plot as well, and to the side a very high I-squared score, considerable variety, considerable heterogeneity between the studies here. And on the forest plot you can see some studies demonstrating a clear benefit of low-calorie sweeteners, some studies demonstrating a clear benefit of water or nothing. For adverse events, 4 studies actually provided data on adverse events for this research question. 3 of them provided data which could be analysed, but we didn't undertake any analyses. We pre-specified we would only analyse where we had data from 4 studies or more to avoid misrepresenting the data. So we didn't undertake any analyses here. But simply counting up the number of adverse events, you can see 13 adverse events in those 4 studies for low-calorie sweeteners and 0 for the comparator arms. So a suggestion may be that there might be more adverse events in these studies in the low-calorie sweetener groups compared to the others. We find no effects or inconsistent effects again in our other measures of body weight, BMI, and anthropometry, and we find similar inconsistent effects in our sensitivity analyses. We also find inconsistent effects in energy intake. So we have here the forest plots for energy intake from the parallel group studies, and you can see here in actual fact we find a benefit here of water or nothing, a benefit of the comparator where individuals in the comparator arms were consuming approximately 676 kilojoules per day less than those in the low-calorie sweetener arms. But interestingly, if we do the analyses in our crossover studies, we find exactly the reverse. So again, very inconsistent effects, difficult to draw any conclusions for this research question. For our 3rd research question, the effects of low-calorie sweeteners in capsules compared to placebo capsules. Here we had 16 studies including children and adults, and again the majority including males and females. Again, a range of low-calorie sweeteners used, and you can see here some very high doses of low-calorie sweeteners, 5 grams per day of aspartame given in one of these studies, and individuals consumed that level of low-calorie sweetener for approximately 12 or 13 weeks in that one particular study. Median duration of the study is 13 weeks, and the comparator was always placebo. Our forest plot here, again you can see a diamond very clearly on the 0 line, no effects here for low-calorie sweeteners in capsules compared to placebo capsules. You can also see no effects in the adverse events, or no differences in the adverse events. You can see from those 2 results as well an I-squared score of 0. So again, a very consistent finding, a very convincing finding, no heterogeneity, and you can see that nicely in the forest plot too. We also find no effects, some slight inconsistent effects in our other measures of body weight, BMI, and anthropometry, and our sensitivity analyses. We did also undertake a number of exploratory analyses just in our low-calorie sweetener versus sugar parallel group studies, because that was the biggest data set that we had. These exploratory analyses looked at the effects of the intervention, whether the effects of the intervention were affected by various aspects of methodology. You can see here we found no associations dependent on duration of the study. We did find a positive association with sugar dose, so the amount of energy replaced by low-calorie sweeteners did have a positive impact on the extent of the intervention or the effects of the intervention. We also, though, found no effects based on blinding, based on whether low-calorie sweeteners were provided in beverages or foods and beverages, and also whether studies were funded by industry or not. To summarise our findings then, we identified a considerable number of studies as part of our systematic review process, and almost all studies relevant to the first two questions were designed deliberately to test those questions in real-life settings. For our first research question, low-calorie sweeteners resulted in reduced body weight, BMI, and energy intake compared to sugar with no adverse events. Our effect sizes are small to moderate, 1 kilogram change in body weight, or a reduction in energy intake of approximately 940 kilojoules per day. But the size of these effects might not be surprising when you remember that the average study, or the average amount of energy replaced in these studies, was approximately 1300 kilojoules per day. So some partial compensation demonstrated by individuals. For our second two research questions, low-calorie sweeteners had no effects compared to water or nothing, and low-calorie sweeteners in capsules had no effects compared to placebo capsules. Taking all findings together then, the effects of low-calorie sweeteners that we find on body weight and energy intake would appear to be entirely due to their energy content or the lack of energy in low-calorie sweeteners. We find no effects as a result of taste and no effects, no post-ingestive effects. Other studies also at present are demonstrating a lack of post-ingestive effects from low-calorie sweeteners. If we compare our findings with those of other reviews, earlier reviews did demonstrate, again, benefits of low-calorie sweeteners. More recent reviews have suggested a lack of effects. Our review is, or the findings of our review are very similar to those just presented by Dr. Laviata. Our review differs slightly from his in that we have slightly more studies. Our review is published slightly later, so more have been published. We also included abstracts. We also included studies that only needed to last for a week as opposed to 4 weeks. We also investigated effects on energy intake, but also interestingly, we excluded 2 studies that were included by Dr. Laviata because the low-calorie sweetener intervention in those studies was confounded with other strategies for reducing sugar-sweetened beverage intake. So we did, in our review, we did include studies that included or that involved other interventions as well, but we only included those if the other intervention was also present in the comparator group. So in these 2 studies, the low-calorie sweetener intervention was confounded by this other potential intervention. Just to finish in terms of practical recommendations, from the findings of our review, low-calorie sweeteners can be recommended for impacts on body weight when consumed in place of sugar. The size of effects will reflect the amount of energy replaced and will depend on the degree of compensation by the individual. Obviously, the more energy that's replaced, the bigger the effects, something that Dr. Laviata mentioned also, and also the less compensation by the individual, the bigger the effects. Low-calorie sweeteners then may be beneficial, particularly in situations where other aspects of the diet are also controlled, but at the same time, practitioners and individuals, consumers, need to be realistic. Importantly, we found no evidence of increased adverse events, and we can make no recommendations for low-calorie sweeteners versus water or vice versa. The evidence is very inconsistent and more evidence is clearly required. To finish, the work reported here received no external funding, but I do have funding from industry for other work on sweet taste, as does my collaborator. And finally, I acknowledge Peter Rogers from the University of Bristol, who collaborated obviously on this work. The reference is there. It's not published in print yet, but it's published online on the website. My email also, and one of my recent reviews also looking at the post-ingestive effects of low-calorie sweeteners. Thank you.
Oh, thank you very much, Dr. Appleton. Two excellent presentations, very clear reviews. So let us open up now for a couple of questions. We have a number in the queue. Let me start with one. In many of the trials, the low-calorie sweeteners are presented in a beverage. That's clearly the most common way that they are used, but they're increasingly incorporated into foods as well. To what degree can you isolate the effects that you've seen to the sweetener versus the vehicle in which it's delivered? Do you think the results will differ if it's presented in a beverage versus a solid food, for example?
Well, I can very quickly kind of answer. We actually looked specifically at were there any differences between studies where low-calorie sweeteners were presented in beverages versus those where they were presented in foods and beverages together. I don't think we had any studies where low-calorie sweeteners were only presented in foods, but we found no differences in the effects of low-calorie sweeteners in those studies.
All right, thank you. Second, we had a question. You had mentioned, Dr. Appleton, that there were 13 reports of adverse effects with low-calorie sweeteners and none in the other groups. Mm-hmm. Can you share what those effects were? What was the nature of them?
No, sorry, off the top of my head, I can't provide that. It was interesting actually, they were reported in the studies specifically that were looking at low-calorie sweeteners versus water or nothing. Whereas when we were looking at low-calorie sweeteners versus sugar, there were very few adverse events in either arm. They would be relatively small effects, gastrointestinal discomfort, these types of things. Nothing kind of serious, major, but yeah, and enough for people to report them in a study. But yeah.
Thanks. Dr. Laviata, you mentioned that you have an interest in studying effects, not just in normal, healthy individuals, but also in diabetics and so on. Do you have any reason to believe that effects would differ between those populations, or that there'd be an added benefit in one group or another?
What we have reviewed in the literature regarding the effect of these additives in diabetics is that it seems with the results which are published in this recent Cochrane review by Lohner, that when you compare also with placebo, there is absolutely no effect. So the benefit will be the substitution of sugar, and low-calorie sweeteners are not drugs. And in some papers, it seems that they expect to behave as drugs, are not drugs, and it could be a useful tool for reducing sugar intake, as Dr. Appleton showed in the results and also in ours. The benefit is related to the displacement of energy, and in people with diabetes who may be useful to reduce sugar intake, it can be a way to reduce and to substitute. Not indispensable, because you can use, for example, in beverages, water instead of low-calorie sweeteners beverages. But for people who want the transition from sweet taste and wants to substitute it with these additives, is a good choice.
Both of you commented on distinctions between randomized controlled trials and cohort studies, prospective cohort studies, and commented that RCTs are sort of a higher level, considered a higher level of science. If that's the case, is there value in the cohort studies? Should we continue to do them? What role do they play at this point?
Yeah.
What I think is that they are valuable. Every study teach something to us. For example, if you see the observational studies, when you do the adequate statistical adjustments, you can see quite a good match with the results of randomized clinical trials. The problem, I think, is not the studies, the studies or the trials themselves. The problem is the interpretation. And what we have to look is to see to all the evidence we have and to try to understand the differences and the coincidences, and to explain these differences and these coincidences. But I think all the evidence is useful.
I agree with that entirely. I think there's value to all types of study, but yeah, you have to treat them all as respect what they contribute and what they don't. There's value to all different types, but there are problems with them all as well. So yeah, I agree.
So the primary outcome of both of your reviews was something body weight related, adiposity, but there are other outcomes that one might look at, blood sugar, for example. Can you comment on sort of the broader picture, the broader role of use of low-calorie sweeteners? Are we, by focusing on one outcome, missing important health implications that you want to bring to light?
Can I start? I think Dr. Laviata will manage a more comprehensive answer to this one, but to really pick up on the point that we just made, I can make no comment on other aspects of health, essentially, because that's not what we looked at in our systematic review. We only looked at effects on body weight and energy intake, BMI, and only then as well anthropometry, where it was included in the studies that we'd already picked up. So yeah, I think it would be very irresponsible of me, essentially, to make any suggestions. But it's that's based on our specific work. I think Dr. Laviata works more in the kind of field of differing populations. So I shall let him answer as well.
Yes, if we go again to see some observational studies. The low-calorie sweeteners have not been associated just with obesity, also with some metabolic and cardiovascular outcomes in this observational design. But if we consider that obesity is the primary factor, the generator of some of these diseases like diabetes, cardiovascular disease, dementia, and hypertension, you can interpret maybe the same, that maybe can have, and if you review in the other side, the randomized clinical trials and this modest but constant effect when you substitute sugar, you can infer that this modest benefit can be traduced also in outcomes related to the metabolic disorders related to obesity. But it is as Katherine said, it is not responsible to assume this in an absolute manner, because we don't have randomized clinical trials, and maybe we won't have, because you need for some outcomes like for example cardiovascular disease, or you may not impact them for if you don't perform very long randomized clinical trials. And maybe the other thing to consider is that we have to admit that this is a weak intervention. It's not a powerful intervention. So it can help to contribute with a grain of sand if you substitute sugar. But as we have seen, compared, for example, with a complete weight reduction strategy, it seems to look to be an effective but relatively weak intervention.
Let me follow up on that, because I think it's a very important point for those listening and are going to read the literature, the primary literature on this. You both had to make decisions about which papers to include and which to exclude, and one of your criteria was duration of intervention. You make the point, and especially it's true for weight outcomes as well. People don't lose a lot of weight overnight. It takes time for this to play out. What's a reasonable minimal study duration? I know you wanted to be as inclusive of the literature as you could be when you conducted your reviews, but help a clinician understand what's a reasonable minimal duration of a trial to draw conclusions.
The answer to that, of course, Rick, depends on the intervention that you're implementing. Some interventions, of course, will have massive effects and relatively quickly, whereas others, of course, won't. But at the same time, they won't be sustainable for any amount of time either. We obviously, between us, chose different periods of time. For our review, we chose any interventions longer than a week, because there are some studies that demonstrate effects after a week in body weight. But we were also looking at energy intake, and you can expect energy intake a bit more reliably. I think more people would expect energy intake differences over a week. But yeah, we wanted to be as inclusive as possible. So yeah, included a shorter time frame.
We're just about out of time. I do want to ask one final question. You know, there have been a fair number of studies on this topic now, and as you just outlined, a number of systematic reviews, but it doesn't seem to be changing policy or consumer behavior a great deal. What is it that needs to be done? What gaps in knowledge do we still have to fill to make a convincing story, one way or another, to bring about change?
One thing that I think there is a limitation and have to be explored, and is that in these systematic reviews we put together many different low-calorie sweeteners. It's not the same aspartame, it's not the same stevia, it's not the same sucralose or acesulfame K. So what we do to have a robust systematic review and meta-analysis is to put together all of them. But I think that as they have different metabolic fate, different molecules, the fair thing to do is to examine them as separate molecules, and is maybe a great limitation to include them together. I think it's valuable information, but the meta-analysis of each of the molecules separately, it will be worth.
All right, I think we are out of time. Marie, do you want to close?
Sure, I would be happy to do that. So this brings us to the close. Thanks so much, Dr. Laviata and Dr. Appleton, for sharing your insights with us today. Just another reminder that everyone will receive that short survey after this webinar and complete that to receive your certificate. We just want to thank everyone for participating with us, and we hope you have a great afternoon.
Thank you, everyone. So
Thank
long.
you.
Thank you.